Michael is with us from the Stedman Clinic in Vail, where they're getting lots of snow, and we all want to get there very soon. So, Michael, why don't you drive us through? But maybe I'll sort of set the stage here. Cervical pedicle screws, obviously, we've not been very. They haven't been used a lot because the difficulty, it's tiger country. So which are the cases that you really feel are the best for cervical pedicle screw fixation? What are your indications for this right now?
Yeah, I think that's the indication for this is really at the heart of the use case. And for me, as we start doing it, my practice is primarily adult degenerative. And so as we get larger and larger cases, especially from the front, and we really want to do something like a 4-level ACDF. And we know through the literature, the rate of non-union for that case is somewhere between 15 and 30%, depending on the papers you look at. And so being able to provide a higher reliability, especially as we get some anterior surgery down at the cervical thoracic junction, C7, T1, and be able to flip that patient and efficiently lock them down and be able to instrument them from the back, whether we need to add a decompression or a fusion with that as well, but to at least get the strongest fixation we can to help increase that healing rate and decrease that non-union rate to something that's more acceptable as a 1 or 2 level ACDF or patients that have had poor comorbidities to really enhance their bony healing by doing a minimally invasive surgery, percutaneous, limit the soft tissue damage, but increase that healing rate to be able to have them have a better outcome with less chance of coming back with a non-union revision situation.
Awesome. So why don't you take us through the steps?
Yeah, absolutely. So obviously they have to be the right candidate, and you can look on their MRI scan to kind of guesstimate whether you can get screws in. And I typically on these patients do a preoperative CT scan to evaluate them to see if I can get those screws in. We happen to have an amazing cadaver here provided by the Seattle Science Foundation and all the work that went in behind this to get this prepped. And so really what I like to do, and you can see here, when I place a DRB, it's kind of in the lower portion of the field, upper thoracic spine. Usually I like to be at least 2 to 3 levels away from my last instrumentation level. This is approximately at the T3 zone because we're going down to T1. And then the angulation, being able to have the correct orientation in the room to be able to have all the line of sight available for some of these screw trajectories. And what I really want to do is we have the pre-planned side where I'm going to drop the screws on the left side, but I wanted to go through a little bit of the planning because within the cervical spine and upper thoracic junction, there is a little bit of that necessity to avoid structures such as the vertebral artery. So when we're going through and I'm planning and dropping screws, I usually like to start here on the axial, and then I sort of start navigating around where I want that screw trajectory to be, obviously avoiding the neural elements of the central canal, but also making sure we have enough bandwidth within the pedicles themselves to be able to dilate and drop down the appropriate size screws. I typically like using 3-5 screws and sort of, looking at that anterior border or ventral border of how deep I can actually place them. And so with the Excelsius system, you can really customize that trajectory to get them, almost exactly where you want to place them. And then you can check within the pedicle view exactly that you're going down the pipe. And so once we have it in a nice sagittal alignment, I just continue to drag and drop, shorten them as necessary. Usually 16 is a 16 screw is what I'm looking for, but also as I'm going down in that particular view, that en face view, making sure that I'm going through that entire bony channel and not wandering cranial or caudal, so I invade the neuroforamen, and also avoiding any sort of vertebral artery structure or other elements that we can do. There are surgeons I typically have done percutaneously, probably about under 10 of these cases. There are people in Europe and throughout the United States trying to do upper cervical stuff. And I think before you move to the more dangerous and more complex things in the cervical spine, just like in the lumbar spine, you want to do reproducible, high probability surgeries that you're going to get a good result from. So starting at the cervical thoracic junction, I think especially for ACDFs where you are going down to that 7-1 level, we know that that has a large lever arm and a high risk of non-union. Being able to perk those from the back and give yourself that confidence that you can do this. And I think it was mentioned earlier about sort of smooth is fast. And so really, you don't want to push. The cervical spine is a little more flexible, obviously, than the lumbar spine. I always do this with a Mayfield head holder holding the position. With a cadaver, we have a little bit different setup, but really being delicate and not really pushing, letting the drill do the work. And that's one of the biggest tips that I can give you in doing this procedure. So, want to place some screws?
Yes, absolutely.
All right.
Take us there. Show us the finesse of the procedure.
So obviously you go to the navigate portion and get the arm to drill. I like to sort of pre-plan all the trajectories and I mark them with a little pen. And you know, this may chew a little bit of time, but it also helps me plan my incisions. In the lumbar spine, sometimes with the extra lordosis that you get, you can get a little bit of a wiltsy opinion or surgical incision there instead of doing it a true perk. But I like to at least look at and map out, and the skin filter on this also helps us to do that. I planned 5 screws today just to see and just so you can see any sort of matching of this is reasonable.
So here's my first lesson of the day. What you just did with the marking pen, dropping it down like that. I've never seen that before, and I'm always struggling with the marking pen, looking at the tip of the end effector, putting my line and saying, okay, the line's kind of close, but you know you're a little bit off. That's a great little trick there. I'm going to start using that.
Yeah, it's a little, you know, I always tried to get them to actually make just a little pen so you could just plop it down, but, you know, Gotta work with what you got. I don't think there's a lot of money in the pen industry. But you know, this is how I plan all my incisions, even with lumbar, and then it allows me, because I know if I bisect that circle, I'm going to be kind of right where I want to be. So I continue to just go through and sort of drop these. And essentially, we're creating sort of the same effect as like a wiltsy incision in the lumbar spine, just kind of going through in the paraspinal muscles in the back of the neck. And one of the things that, another technology that I use is I do use Aquamanus quite a bit, especially because the back of the neck bleeds. And I want to make sure we're getting good hemostasis after I use the knife to get down. And so what I'm going to do right now is I'm going to come off navigation here, and I'm just going to kind of move the robot so you can sort of see the skin incision that we have planned. So they're all, in some ways, quite close. The thoracic one is a little bit more down. And you could do an incision on the skin, and that's likely what I will do. But then through the muscle itself, they're all sort of the percutaneous part. And really, as things evolve and the screw technology in the cervical spine evolves, this will start to mirror and start looking more and more like our lumbar surgeries that we're doing currently. Unfortunately, we don't have that today, but in spite of that, we're going to drop some screws percutaneously, spare that muscle, prevent that dissection of the muscle off the spinous process and actually off the bone, and be able to place these efficiently. So, I like to start in the lowest segmented, obviously, making sure that we're in the correct area, that everything matches up. I do use the chicken foot to sort of verify my location, check it on the spinous process, make sure we're in the right domain. And that's just a little check I do just to make sure, like everything else, trust but verify.
Michael, do you ever use a longer midline skin incision as opposed to two paramedian incisions?
You know, that's a great question. Some people kind of go the center skin and then actually bring the skin folds out and then kind of perk your screws. I tend to do more of like a triple stab if I'm going to do something like that. So I really like convergent, long, and very angled, high angulation screws for the pull-out strength. And then if I'm going to a midline, I'll actually do like a little center. Either you could use a McCullough or a tube or endoscopically to be able to do that decompression in the middle. So because my screws tend to be very highly angulated, I'm usually pretty far away from sort of getting that fascia and skin far enough away to be able to accommodate that.
Fair enough.
So one of the nice things about this is, you got to use all your senses with the robot. Despite it being an amazing aiming trajectory machine, really you still have to feel the bone. You want the drill, you want the knife to hit bone. And in the lumbar spine, I always plan it to actually hit a transverse process. So when I feel that, I get that positive stop right on the bone. And the three different tools I use before I put the screw in, I like that high-speed burr. That kind of makes a nice little crater or divot. That helps the secondary drill not to wander. And then I do tap these. I tap by hand. In the lumbar spine, when I'm doing robotic cases, I typically use power for my taps. And then again, I stimulate all the tap as well as the screw to do that. So what I'll do is just start making an incision through the skin on this portion. And as you go in the upper thoracic, lower cervical junction, if you're trying to do some of these screws perk, let's say to T2 or T3, you do have to remember that there are multiple muscle planes you're going through, the traps, the rhomboids, different bigger muscular groups that we're typically not thinking about when we do our standard midline approach for the posterior cervical. So that's just one thing to recognize if you are starting to do this, really talking to your patients about that upper trap pain. That's going to be something different that a lot of folks don't necessarily have when you're doing that midline dissection, but you are further out in the musculature, and just to be thoughtful about informing patients about that.
So, Michael, I see the room set up the way you have it there now. The robot's at your left arm with the screen essentially over the head.
Yeah.
Is that the typical setup you have in the operating room for this?
Yes.
And
Yep.
does that not, how does the anesthesiologist deal with crowding in that area like that?
I mean, I think they're usually pretty good about it. We've done enough of these cases where they've been okay with it, as long as they have access to their head and sort of underneath the drapes, it's okay. Sometimes I do have the robot maybe a little closer to me this way, just to give them a little more space. But I do try and push the envelope for them on their comfort with this, because for me, they obviously have to be able to get to the face, to get to the head, and be able to do all their jobs for safety. But also I need to have this in the best position. So it's usually a compromise between the two of just kind of seeing what their tolerance is for how close they'll get it versus where I actually need the robot to be itself. So with the knife, I always spin it within the machine, but I do want that nice positive stop. And, it's not that I'm pushing. I just want to push to feel that bone right there and get that stop. Once I have that, if you're just starting out, you may want to just sort of feel and verify that we're sort of in the location that we want to be in. And then it's just a series of steps with the drill. I always test it. You know, we get a lot of travelers nowadays, especially with implementing robotic technology. We have like a whole training program that we put any new scrub through. They have to be able to be working with someone who's done robotic cases with me before they're allowed to function independently. I think that's, you know, really important in creating a good workflow with the team to be able to have that training because we are all faced right now with a significant shortage of those surgical techs and nurses that really start slowing down some of the implementation of technology. So again, I always make sure my offset meter is zeroed out and that it's sliding smooth. And then I kind of do, you know, I want to check each plane. So I want to make sure my cranial to caudal, medial to lateral is good. I lift off the bone and then I slowly advance to the bone. And I want to hear that engagement, right? You know, again, using all your senses, I can hear it starting to slow down and I can feel that and hear that. And really this is all about just making that crater again for the next drill so I can be able to efficiently put this down. Now I will tell you this is the puckering part of the procedure. Being able to get this perfectly set up. And this is where the steady hands are required. So even though, you know, some of my patients say, oh, doesn't the robot do it for you? And I was like, yeah, not yet. But the other thing that you can run into is you can get some cortical channels in these pedicles, especially at more degenerative cases. And again, letting the drill really do the work. I'm not forcing this. I'm really not pushing that hard. And once I get that nice opening, you almost feel it release. You're drilling, 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 and then you feel this release. And that's that point where you want to make sure you're dead on. Again, always checking and verifying. Sometimes you can get post spins afterwards, especially in the cervical spine. I think if you're using this for the first time, it's a very, very good idea until you place a lot of screws that you're checking these screw placements afterwards. Another thing with this driver in our setup right now, this can sometimes loosen, and that's just something that you check as you're putting the screw down itself. And making sure that soft tissue isn't impeding you as you're placing the screw. Again, I don't use power in the cervical spine.
How does the purchase in the bone feel?
It is a rock, which is awesome. And that's what you kind of want at the end of your construct. And you can see that we're staying on course. And if you could come in here and give this a turn, you'd be like, wow, that is a solid, solid, solid screw.
So this is where I feel one of the big advantages of the cervical pedicle screws compared to the lateral mass is you do get that tremendous purchase, especially in a lot of the older degeneratives where you know the lateral mass is just a hollow box of bone. So I like to take advantage of that purchase as much as possible.
And sometimes I totally agree with you. And you know, when you're doing this, The real question will be in research in biomechanics, and maybe the AI program that you have could help answer some of these questions, is do we need to actually place screws at every single level, or can we do because it's a short segment, could we place one at the cranial aspect, place one at the caudal aspect, and maybe one in the middle? Is that enough? And the real fixation question is, if we're doing this bilaterally, do we need to place a screw at every single level? Can we skip levels? And I think really figuring that portion out will help accelerate this process, but also decrease the amount of soft tissue damage that we're doing, especially if we're backing up like a 4, or sometimes people are even pushing to 5-level ACDFs. I don't personally do 5-level ACDFs, but when you're doing that, you might be able to go to zero profile plating. Maybe you don't have a plate on front. So there's less risk of dysphagia because now you're not introducing a large metal piece that's pushing on front, especially in those longer single plate constructs, and being able to percutaneously back this up. There's just a whole lot more research that needs to be done to really find the ideal configurations to help patients navigate this. So right now I'll place one at C5. That's a little dicier in terms of the ability to do it. So again, I have my skin already marked, which is nice.
So Michael, there was a question here from Terry. Do you stimulate these cervical pedicle screws?
I do. Yep, I do.
Do you change the voltage parameters in any way?
In the lumbar, I'm really shooting for 20s almost every time. In the cervical spine, I think you have to lower the threshold. There's a lot less bone around. Typically in the 14, 15 range, I'm pretty happy with. Obviously, I really don't accept anything less than 10, ever. What are your thoughts on that?
I have not been stimulating them. Principally because I'm paranoid. I'm right next to the cord. I just don't want to fry anything. Maybe I just don't want to know the answer.
Yeah.
See, the misconception here is that the spinal cord is at risk with cervical pedicle screws. But if you look at that bottom right image that you have, you're already below the equator of the spinal cord with your starting point. So it's really not the spinal cord that you're worried about. It's the traversing nerve root.
Yes.
The vertebral artery that's most concerning.
Absolutely. I think that's 100% spot on. And, I think we can accept a little bit of medial side, but obviously going into that little circular thing on the lateral aspect is a bad day for anybody. And of course, being able to plan, I get an intra-op, especially if I'm backing up an ACDF, I'm going to do an intra-op spin because I want to see how the anatomy has changed, because sometimes I use some hyperlordotic anterior inner bodies, and that will change that preoperative CT and may change some of the location of my screws, making I find that as you add more lordosis, your screws and robotics always tend to be more convergent and start coming through the same holes, as opposed to if you do your screws first and then you start doing your bony work. I see the holes sort of change, or the incisions where those screws are coming from change as you sort of do your pedicle subtraction osteotomy or something like that. And especially if you have towers through the skin, that can actually be a tether for some of that correction. So again, I kind of lift off the bone to start, get it spinning. And really, you just have to let the drill do the work. And it's a little bit, you have a lot more leeway in the lumbar spine. But in the cervical spine, you really got to just let the drill slowly do this. And when you're doing this live on a real person, that step right there is the pucker factor, right? You have a high-speed spinning drill. You're right next to the vertebral artery. You're right next to the nerve roots coming out, and you're spinning a drill. So that's the part where the touch, the feel, and just being very smooth and controlled with how things are going. And then this sort of becomes more of the fun part, where you're aligning your tap, you're getting in that hole that you've just drilled, and because of the robotics rigidity, you're really able to continue tapping down that line. I'd probably stim the screw there. I slightly under tap a few millimeters just so I can get that extra bite at the end. And everything really has to be smooth and in line. I always check to make sure that everything is locked and in place. That's just a habit that I've gotten into from having a diversity of different techs. Sometimes the screws aren't all the way locked, and the last thing you want is a loose screw in the neck. And really, this is just like placing any other screw that you have done before, and it's just that feel. I like these 3 fingers. I don't crank typically. I really like just the finger tightness.
Yeah, that far left image that we see now, I refer to that as the finesse component. This is where you really have to know the feel.
And right when you get to that cortical, and you can see it, the nice thing is you can actually see like, oh, why is this getting a little tougher? And you're like, oh, there's a huge bunch of white cortical type bone, sclerotic bone that I'm going through. Good. And you can see I'm really holding this with my left hand. They've made these little divots on either side for you to be able to pinch, but that's really allowing me to hold it and stay in line. And I think as anyone starts to do this, really it's, control and how you're doing it. So there we go. That's a 5 screw. Looks great, right on trajectory. Got a nice check mark, which is a nice validation that it's within less than 2 millimeters of the variation.
So we've only got a couple minutes. So are you going to place a rod?
We could try to do that. Let me get the little measuring. I don't think we have a little setup for a rod, but we can try.
If you don't worry about it.
Eventually, the nice thing is, I think in the future, some of the improvements that we could do is have those goalposts like we do in the lumbar spine to be able to pass that rod efficiently and then be able to lock that down appropriately. Very similar to most of the tabbed screw systems in the lumbar spine.
So Michael, give the participants your one most important pearl for placing cervical pedicle screws.
Take your time. Do not push.
Perfect.
You push the cervical spine, you're going to start flexing it, and that's when you're going to run into problems.
Brilliant. Any questions from the audience at all? Go ahead, Hendrik.
So when we're doing the right lumbar, we usually start as far away from the area as possible and sort of serpentine better. Thanks. When we're doing thoracolumbar constructs, we're generally starting at as far away from the DRB and working ourselves serpentine back in so that we are, using, because we talked about how like the tap, it's so sclerotic and you place the screw, there's going to be every force is equal and opposite force, right? So you're twisting it in, you're pushing a little, it's going to pull up a little bit. So you have the spine kind of move up a little bit on this side, then you go to the other side, right? And you work yourself down in this delicate dance. Here, you had mentioned that you like to start in the caudalmost segment and work yourself cranial. And I just wondered if there was, if that was just, why was that your preference?
Yeah, so like the snake pattern that people talk about going one side, one side, one side, one side. I'm almost close to 300 robotic cases. And I was always taught, like early on, and maybe it was because of the training that I received, that if you could get one side done completely and the patient didn't do well, but one side was instrumented and you could drop a rod and get them off the table, that was ideal, because at least they were backed up on one side. So I typically like to start from sort of the most solid screw that I'm going to place, and that gives me a lot of more confidence in the cervical spine as I move up, that I know that, hey, that first screw was perfect. It's exactly where I want it. It felt good. It looked good. And then you can start to go to what I just did here and go to that cranial most screw and drop that. And then once you have those 2 points of fixation, if nothing else worked out, you have the ability to lock that down. And so that's kind of my philosophy on this is, if there was ever any problem with anesthesia, or the patient wasn't doing well, or some sort of issue happened within the procedure, you're at least able to lock down the cranial and caudal aspect and have a successful backup on the procedure, so you actually completed part of your goal.
Awesome. I think that question, this discussion really highlights one of the benefits here, is that you can do multiple things. It's not one strict method for every case, for every patient, or for every surgeon. You can adjust as you can with the technology that we have.
Yep.
So it's good. Any other questions? Awesome. Michael, thank you. Well done.
Hey, appreciate it. Thank you, guys.